Hello guys, a very good evening. Hope I'm audible and visible. Okay, so we are discussing pathology after a long time on YouTube, right? I hope you guys are doing well and I hope your preparation is up to the mark and your exam is supposed to be on March 5th. And I hope it happens on time and the counseling also happens on time, right? So what you're going to do is today is we're going to see few mixed bag questions. Hello Sachin, hope you're doing good. Same routine. We'll be discussing a few questions and then we will try to find out the answers for them and discuss some topic related to that. It's going to be the entire covering the entire pathology. So let's see if we can learn a little bit more from today's class, right? So there's an NEET PG 2023 All Educator Ultimate Revision batch which is coming on. So on September 30th, that's tomorrow. If you want to enroll to that, please go ahead and do that. There is a course for FMGE exam as well. There's a 2.0 Q bank available. I'd request you to attend these questions and give the question feedback for me because I'll be able to try to improve them and hopefully for it'll be useful for your upcoming exams. Fine. And there's an offer as well. So if you want to use any code, you can use any code, whatever you have, or you can use other cups. Fine. Let's go ahead. So I'm going to display the first question. I want all of the guys watching the video to comment on the right answer. It doesn't matter if you're right or wrong, doesn't matter at all. Don't worry that if another person is going to tease you. If you feel that another person will be teasing you, create a unique ID with a random name XYZ, right? We have to learn. That's all. That's our ultimate aim for us, right? Okay, this is the first question. I'll keep myself muted for 30 seconds. I want you to comment on the answer. Please do comment on the answer. These are easy questions. Okay, anyone? Anyone wants to come to the right answer? We'll consider them ABCD itself. It's FNA of a non-tender mobile mass of the breast, which will show which of the following. Okay, see, I'll give you leading questions, leading options, or leading way to come to the answer if it's difficult. FNA of a non-tender mobile mass from the breast. What do you think is a clinical diagnosis in this patient? You must have had a clinical diagnosis, right? Okay, Vignesh has gone with A. Let's see if it's right or not. What do you think is a clinical diagnosis of this patient? That's a very easy question. I'm sure most of you guys will know the answer. It's a simple fibroadenoma, right? I hope all of you guys will accept that a non-tender mobile mass in the breast I have to think of fibroadenoma, right? Okay. Now my question is a bit simplified. Which of the following will be the right answer for an FNAC of a fibroadenoma? Let's assume that I don't know anything regarding FNAC of breast. Even then, we can try to rule out few options. Fibroadenoma is a benign or a malignant condition. Again, a leading question. Fibroadenoma is a benign condition or a malignant condition? See, we need not know high-fi things. If you know very, very simple basic things, we can answer the question. Fibroadenoma is definitely a benign condition, right? Perfect. All of you will agree that fibroadenoma is benign condition, right? Look at option B. This causes a population of pleomorphic ductal cells. Pleomorphism. This word is diagnostic of benign or malignant. Again, a very, very simple question. Pleomorphism is diagnostic of malignancy or a benign condition. Again, most of you guys will accept that it's diagnostic of a malignant condition, right? So can I rule this out? Definitely, I'm not going to have a malignant condition, which will be the FNAC finding of fibroadenoma. I can rule that out, right? Third option, right? Sheets of plasmacytoid cells with background lymphocytes. Fibroadenoma is a benign lesion, right? Benign tumor. Do you think it'll have lots of plasmacytoid cells and lymphocytes? Option C, is that possible? Plasma cells, lymphocytes are generally seen in an autoimmune condition, right? Might be in inflammation. It's not a finding seen in a tumor cell, right? So option C is also not possible. Just keeping in mind, it's a benign condition. It's fibroadenoma, that's all. We look at option D. Option D starts with atypical cells. There's only one atypical, ignore that. Atypical cells, diagnostic of benign or malignant. And also if you follow up, it's mitotically active stromal cells. Benign or malignant? Perfect, right? That's all. Like what Aisha said, whenever I'm going to see of atypical cells, I have to, and mitotic active cell, I have to think of malignancy. So this also is ruled out. When you have an MCQ, whatever MCQ it is, if you don't know the topic, don't stop it. You can still write the answer even without knowing anything about the topic, right? You need not know how to identify FNAC of breast. But option B and option D is suggestive of malignancy. Option C most likely an inflammatory lesion, which is not fibroadenoma. So only one option which is left is tightly arranged ductal epithelial cells and discursive bar nuclei, right? So if you have any difficult question, I want you to approach like this. But yes, since if we are reading it, we'll learn why it's tightly cohesive and everything soon, right? Let's say we'll take back from the name itself, it's fibroadenoma, right? So can I say with confidence that in fibroadenoma, there'll be proliferation of both stromal element as well as epithelial element? Am I right in saying that? It's fibroadenoma. Can I have both proliferation of stromal and epithelial element? Definitely, right? So the epithelial element in a breast tissue is ducts. Stromal element is normal stroma, right? So I have both stromal element and epithelial element hyperplasia or a neoplastic proliferation. Which of these do you think is stronger? Epithelial or stromal? Stroma is definitely strong, right? Stroma is definitely strong because stroma is made of your mesenchyme, collagen, fibrous tissue. It is definitely strong. So can I say in other words, when I have both proliferation of epithelium and stroma, the stroma will compress my epithelium. Is that right statement? Because stroma is stronger than my epithelium, stroma will definitely compress the epithelium, right? Let's assume that my normal epithelium was like this, ducts. In between, add stroma. Stroma generally will be pink in appearance, right? And as generally stroma like this, right? Pink color. So when I have more and more of stromal hyperplasia, in addition to my epithelial hyperplasia, what happens is the stroma will compress my epithelium. It will become like this. It will be like a slit-like space. It will be a compressed epithelium, that's all. The reason being the stroma. The stroma becomes extremely thick and hyperplastic. That will definitely compress my epithelium, right? So when I do an FNAC, am I right in saying that if you're doing an FNAC of this particular lesion, right? I just want you to use the common sense and answer. That's all. It's purely logic and nothing else. I'm doing an FNAC of this lesion. Which cell component do you think will come out easily? The loose or your weak epithelium or the very strong stroma? Which will come out easily? Epithelium or stroma? Whenever I have anything, it should be epithelium, right? Because the easier one will come out easily. When I do an FNAC, stroma will not come outside, epithelium will come outside. Perfect. So this epithelium is going to exactly come like a duct. Stroma will not come outside because stroma is a bit stronger. When I'm going to do an FNAC, I cannot pull out a strong tissue, I can pull out the weak tissue only, right? So can I say in FNAC, when I pull the epithelium, I'll have the same thing full of cells, right? I'll just show you an FNAC of a fibroadenoma. This is how fibroadenoma FNAC looks, right? Can I relate this kind of to be a compressed duct? Does it look like a compressed duct? Just to envision, in the real patient, I'll have lots of stroma here. Since I don't get stroma in FNAC, so this is how it's there, right? So that's how normally it will be, right? So the epithelium alone comes outside. So looking at this epithelium, just tell me, again, very, very basic ideology. Can I call this a cohesive cluster or a discohesive cluster? Just basic things. Is it all the cells are together or all the cells are separated? It's a very basic question again. You know the answer. That's a perfectly cohesive structure, right? It's cohesive structure, that's all. So when I say cohesive structure, I am in breast parenchyma, I am talking about a benign condition. Remember this. These terms I want you to remember soon, right? So when I say something is cohesive, with regards to breast parenchyma, I am thinking of a benign structure. When I see something is discohesive, so just for us for understanding, if it's discohesive, can I kind of extrapolate? There is no E cadron because when E cadron is lost, it becomes discohesive, right? Which means it's an infiltrating tumor, a malignant tumor, right? Generally, if it's discohesive, I'm going to think of a malignant tumor. So this is the primary thing for me for FNAC. A cohesive cluster, wherever you see, it's benign for breast parenchyma. If it's discohesive, not clustered together, let's scatter, like I said, I'm going to think of malignancy, right? Now we'll go and look at the first option. Tightly arranged ductal epithelial cells, which means cohesive, like the image what we saw. And discohesive bare nuclei. The discohesive bare nuclei is nothing but your stroma. This is stroma. Don't get confused here because I'm talking about the fibroadenoma. The stroma will be in the background because stroma is being pulled up. I'm just pulling the stroma with lots of force, so it will definitely disrupt. Epithelium easily comes out just like a cluster, right? So this tightly arranged ductal epithelial cells is diagnostic of fibroadenoma. Fine, perfect. Alia, yeah, this is for abnormal. This can be useful for abnormal growth dysplasia. Yes, this causes for malignant is the easier way to remember. That's all, fine. Okay, great. Now I'm going to show you one more image. I just want only one answer from you. Look at this image. Look at these cells. Okay, look at these cells. Just tell me whether they are cohesive or discohesive. That's the only information I want. I don't want any other information. You may write, you may be right or wrong, but just do comment. It's cohesive or discohesive. That's a very simple question. It's cohesive or discohesive? It's discohesive. Perfect, right? So if you are given a microscopy of an FNAC of a malignant breast tumor, you can easily pick it up. It's discohesive. That's all. It's not just discohesive. Let's look furthermore. Look at this cell and maybe look at this cell. Can I say there's a variation in the size? Some of the cells look bigger, some of the cells look smaller. Sure, Monisha, I'll tell you. Just give me a second. Yes, I can definitely say there is variation in the size and shape of the cell. That's what I'm going to talk as pleomorphism. There's pleomorphism, there's discohesive nature. Definitely, this is suggestive of a malignant breast tumor. That's all, right? That's how you easily pick up a malignant breast tumor. It's very simple. An FNAC cohesive, benign, malignant, it's going to be discohesive, right? Look at this. Look at this. Just I want you to comment on this particular cell, right? Just this particular cell, whichever I have circled or whichever I have marked. Can I say the nucleus is in the center or it is in the periphery? Where do you see the nucleus in this particular cell? This particular cell, any cell here. Most of the cell here, the nucleus is in the center of the cell or in the periphery of the cell. Look at this one. This is even more classical. It's in the periphery of the cell, right? Perfect. So, do you know any inflammatory cell like lymphocyte, plasma cell, neutrophil, and eosinophil? Which inflammatory cell has a peripheral nuclei? There's one inflammatory cell which is characteristically has a peripheral nuclei, which is a plasma cell. Perfect. So these are not plasma cells. These are called as plasmacytoid cell, right? That's what my third option said, right? So these are plasmacytoid cells. I'm just explaining this because that is in one of the options, that's all. So when I have a plasmacytoid cell, can I also say that even in this mirror, I do have lots of pleomorphism, different size and shape? Yes, we do agree that, right? So I do have different size and shape, and these are plasmacytoid. Plasmacytoid cell, if I'm going to have in a microscopy, I will think of an medullary carcinoma of breast. Just keep this in mind. An extra additional information because it was one of the options, right? Medullary carcinoma of breast also will have lots of your inflammatory cells. Lymphocytes will be there, plasma cells will be there, and they'll become plasmacytoid, right? Just remember them. Fine, great. Okay, what does medulla mean? I'll just complete this and I'll take your query of what different types of biopsies, Monisha. Just a second. What does medulla mean? Again, just normal basic things. What does medulla mean? Everything starts from the basics. Medulla means soft. That's all. Cortex and medulla. Bony cortex is cortex. Medulla is soft. That's it. Right? Even your lymph node. Cortex will have lots of your lymphoid follicle. Medulla is hilum, close to medulla. Blood vessels, soft. Medulla means soft. The reason there are few tumors called as medullary carcinoma thyroid, medullary carcinoma breast. All these tumors on palpation will not be firm or hard. That's the reason I have to know this. So let's assume you're an intern, you're sitting in an OPD and you're seeing a mass which is not so firm. Will you think of a malignancy or a benign condition? In general, it's not a firm tumor, firm mass. You'll think of a malignant tumor or benign tumor. Generally, we think of a benign tumor, right? Medullary carcinomas are missed because they are not firm. They have very little desmoplasia. They are a bit softer than the counterpart. I generally tend to think of a benign lesion, so I miss them. So that gives the prognosis. Medullary carcinoma thyroid as well as medullary carcinoma breast doesn't have a good prognosis because they are often missed because medulla means soft. That's all. Okay? That's all medulla means, right? So Monisha, your question of what are the different types of biopsies? See, when if I have to take a pathological specimen, I have multiple things. We'll broadly categorize them into cytology. I'm leaving hematology here just for your systemic pathology, right? Cytology, and I have biopsies. Okay. So in cytology, we have two more things. We have FNAC, that's your fine needle aspiration cytology, which you do in your thyroid, that's very commonly. And you have something called an exfoliation cytology. Can anyone here give me an example of exfoliation cytology? That's a very commonly done cytology, especially for your external genitalia of a woman. Any one example of exfoliation cytology? You must have definitely heard about pap smear, right? Pap smear is an exfoliation cytology. What I mean by that is the cells automatically shed. I don't go and prick the cells. I don't take a cell, I don't prick it, I don't biopsy it. It automatically sheds. So can I say sputum cytology is also exfoliative cytology? I don't go and take out the sputum, right? It's automatically shed. I don't go and biopsy it. Sputum cytology, urine cytology, all of them are exfoliative cytology. Your bronchial alveolar lavage, I don't do anything. I just use the saline, take out all the mucus outside, and go and look at the cells in the mucus. All these are exfoliation. In your dermatology, you must have heard about Sang smear, exfoliation. I'm not doing any active procedure at all. All of them are exfoliative cytology. Right? When it comes to biopsy, again, I have different things. True cut. The true cut is a common biopsy done. It's based on the needle. The needle is called a true cut. So I'll have very tissue core biopsies. Ideally, if I have to name it pathologically, I call them core biopsies or a true cut biopsies, right? We'll have cores of tissue. It can be done for any organ in my body, right? Cores of tissue, right? Needle, incisional, right? Then excisional biopsy. Then I have incisional biopsy. I will take both of them. Okay. Now tell me, if any of you guys are going to examine a patient with lipoma, will you take a biopsy of a lipoma, prove it a lipoma, and then do a surgery, or you will do an upfront surgery? I'm just talking about a simple lipoma in a hand. Will you biopsy it, or you'll do the surgery first? You will do the surgery first, right? No one is going to take a biopsy of a lipoma, prove it as a lipoma, then do a surgery, right? I do surgery. Dermoid cyst, I do surgery. I'll excise it first, right? That is excisional biopsy. Excisional biopsy is both treatment plus diagnosis. I don't go and examine them first. I go and remove them first, then I give it to the pathology department. Pathology department will prove it's a lipoma. That's excisional biopsy. I don't do a pre-operative procedure. I directly go for an excision. Fine. When I say incisional biopsy, let's say there's a patient with an osteosarcoma of the knee, right, in and around the knee. You will remove the limb first, or you will take a biopsy of them and then go ahead and do the surgery. Then I'm going to do the biopsy first, right? That's an incisional biopsy. I incise the big lesion, let's say a 5 centimeter lesion. I take a tiny bit of it. I prove it's a cancer. Then I go ahead with it. It's for anything. Any large tumor, you incise the tumor. For any large lesion, you're going to incise and you take a biopsy. That's my incisional biopsy. Then you're going to treat them. That's the difference between excisional biopsy and incisional biopsy. That's all, right? So incisional biopsy is only diagnostic, not treatment, not curative. Excision is both diagnostic and curative. For fibroadenoma also is excision biopsy. No one these days goes and investigates fibroadenoma. It's a mobile mass, non-tender mass in a young woman. It's fibroadenoma. Clinically diagnosed, proven, excise it. If you're confident, excise it. If you're not confident, let's say like 50-year-old, I do have a bit of risk of a cancer also. That time, yes, I might require an investigation. That's all fine. Okay, I know the difference as well. Fine. Let's go to next question. Again, I'll mute myself for 30 seconds. I want you guys to read the question carefully and answer. It's a very, very simple question. Read it completely and then answer it. I'll go mute. Gosh, give me a second. What you want about FNAC, if you can comment, it'll be much easier for me. Okay, Chitrasan Sharma. Sorry. Gone with A. Anyone else wants to add to it? Sorry. The simple one. It's not a difficult question at all. Let's read through the question. See, the top part of the question is just story. 46-year-old had a radiation for a thyroid neoplasm after regimen. All of them are stories for me, right? So the actual thing starts from this part. The molecular studies by scientists researching for therapy for thyroid neoplasm found an elevated concentration of caspase 9. So my primary thing is caspase 9 is getting elevated. So caspase 9 will be elevated in apoptosis, right? That's all. So which pathway of apoptosis is my question? Is it elevated in the intrinsic pathway or extrinsic pathway? Perfect. It's elevated in your intrinsic pathway of apoptosis, right? To be specific. Intrinsic pathway or your mitochondrial mediated pathway. The question is, which of the following is the most direct responsible for the elevation of concentration of my caspase 9? Which means I have to just run through my intrinsic pathway. If I know the steps of intrinsic pathway, my diagnosis here is going to be very, very simple for me, right? So what happens in the intrinsic pathway is, let's have a stress. In our condition here, the radiation to the gland is a stress here, right? So once the stress happens, there'll be few group of genes which will be elevated, which are called as sensors of cell stress, or BH3 only proteins, your BIM, BIT, BAT, PUMA, NOXA, right? Those will be elevated. Once these are elevated, it will reduce my BCL2, that's anti-apoptotic, and increase your back, that's pro-apoptotic, right? That's what happens. So once back elevates, what's the function of back? Anyone? How does back function? They function by increasing one protein. What is that? Actually increases the one protein exit from the mitochondria. That's your cytochrome. Right? So cytochrome C will be exiting from the mitochondria. Once cytochrome C comes to the cytoplasm, it forms a complex called as apoptosome, and the apoptosome complex is the one which is going to activate my caspase 9. Right? This is in short, right? Perfect. So apoptosome activates caspase 9. So the immediate one responsible for caspase 9 increases apoptosome. Binds with APAF like Dr. Alia said, right? So I don't have APAF or apoptosome in the option. Just before that was cytochrome C. The best answer will be for me cytochrome C. The increased concentration of cytochrome C is the next direct responsible. Before cytochrome C, what happened was my back increased. The option B is also right. Decreased concentration of BH3 protein, this is wrong. Increased concentration of BCL2, this is wrong, because BCL2 reduces and BH3 protein increases. So option B as well as D, both of them are right. But the person who is directly responsible for that is your cytochrome. That's an immediate step, right? So cytochrome C will be a better answer compared to your increase in the concentration of BAX protein, right? Yeah. Great. One asked about, actually, FNAC is nothing but a fine needle aspiration cytology. They do it generally for thyroid neoplasms, right? It's just a normal IM needle which you use. You prick them fastly so that tiny amount of cells will be coming outside in the hub of the needle. We spread it on a smear and look in the microscopy. It's a very, very minimally invasive structure. Can anyone tell me why I can't do a biopsy for thyroid? Because thyroid, the entire diagnostic protocol is based on FNAC. I cannot do a biopsy at all for thyroid. Why? Anyone? A very simple reason. Why can't I do biopsy for thyroid? Sure, Vignesh, give me a second. Capsule is not the problem, Vora. Okay, Dolo 650, I'll take your answer. But why do you think will there be a crisis in case of a tumor where there's no hypo or hyperthyroidism? If it's in hyperthyroid like Graves, yes, I'll have crisis, right? That's what I think you are talking about, right? Adequate cells will be available for sure. It's extremely vascular, right? I would take Pooja's and Voresh Ray answer. It's extremely vascular. But can I say liver is also vascular? Liver is also vascular. Bone marrow. Isn't bone marrow vascular? Bone marrow is definitely vascular, right? It's a vascular organ. I do take biopsy for bone marrow. We do take biopsies for liver, right? Why not thyroid? I do accept it's vascular. That's half of them. The location. The location is the primary reason. If I do a bone marrow biopsy and if it bleeds, I can apply pressure and try to stop the bleeding. But I cannot apply pressure here. I will choke the patient, right? That's why I'm using a minimally invasive procedure so that the bleeding becomes less. Even if it bleeds, I use a cotton and just press it slightly. That's all, right? That's the reason I cannot do a biopsy for thyroid. Most of the time, it's diagnosed based on FNAC only, fine? Okay. Vignesh, this is my intrinsic pathway. The extrinsic pathway stress is generally a virus because an extrinsic pathway. It activates a protein called as FAS ligand. This will bind and this will increase your FADD. FADD stands for fast associated death domain. This will activate my caspase. What are the caspases in extrinsic pathway? Anyone? There are two caspases which will be activated in the extrinsic pathway. Caspase what to what? Caspase 8 and 10 to active caspase 8 and 10, right? Perfect. There are two caspases, 8 or 10. So it's said to be 10 is in human caspase and 8 is in my single cell organism, right? So both 8 and 10, great. Now let's look at this. See, we know about virus. We have been dealing with one virus which is very, very difficult to eradicate for the past 2 years. What do you think is the important property of any virus or any influenza virus for that matter or any virus for that matter? Can a virus mutate? Can a virus mutate? They can and they will definitely mutate, right? So when my body was eliminating a virus based on this phenomenon, the virus saw that, okay, this guy is activating them based on my FAS ligand and activating FADD and activating this caspase. So virus thought that I have to stop them. So what was happening is this happened long back. We didn't learn this long back, that's all, right? So this virus kind of mutated. The virus which started this mutation was cytomegalovirus, which created an enzyme called as flippase. Flippase is actually an enzyme. So this flippase kind of destroyed FADD. So what happened is when it went into a cell, my body activated your extensive pathway apoptosis. The virus entered inside, created flippase, stopped FADD. So can I say here apoptosis will not happen? And can the virus survive for a longer time? They can survive for a longer time, right? True. Yes. So that's what happened here. So again, with the help of COVID, we know one thing. When virus mutates to escape my immune system, will my body also escape? Will my body also improvise? Can I also improvise something to destroy the virus? We do improvise, right? So what happened is when the extrinsic pathway of apoptosis was not working with the help of this flippase, what my body did was my immune system took a detour. This FADD is what which is destroying, right? So what happened is instead of this, there is an increase in something called as RIP complex. Can anyone tell me where you have read RIP complex? If you've read RIP complex, that will activate one more protein called as MLKL, which causes pores in the membrane. Some of you definitely must have read this RIP complex. Where have you read the RIP complex? Okay, we'll definitely know it in a second. It's causing pore in a membrane. It's actually apoptosis. In apoptosis, will you have pores in the plasma membrane or cell membrane? I won't have pores in plasma membrane, right? Which will have cell membrane destruction, necrosis or apoptosis? It'll have necrosis will have cell membrane destruction, right? Perfect. So can I call this as necroptosis? It started as apoptosis, but ended in necrosis. Can I use the term necroptosis? That's how necroptosis happened, right? So necroptosis is not a new method of cell death. Necroptosis is virus tried to escape. My body said, okay, let me kill you. But still my body won. Right? That's where necroptosis came in the background, right? I'll tell you why this is important for me. See, all of you must have definitely evaluated patients with hepatitis. Yes or no? You must have definitely read about hepatitis. Quite a few of you must have seen patients with hepatitis, right? In case of hepatitis, have you read about something called as Councilman bodies? Have you read about Councilman bodies? You must have read about Councilman bodies, right? So can I say hepatitis virus will induce apoptosis in liver? Is that statement correct? Hepatitis will induce apoptosis in liver. That microscopic apoptotic body is called as Councilman body, right? Any hepatitis I can have it. Is that statement right? That's statement right. At the same time, when you evaluate a patient with hepatitis, will there be elevated AST ALT levels? Will you have elevated AST ALT levels in hepatitis? Yes or no? You will have. Definitely my AST ALT levels will be elevated, right? Perfect. Now tell me, in which condition of cell death the AST ALT or any enzymes will be elevated? An enzyme level will be elevated when there's a cell membrane damage and necrosis, or no cell membrane damage and apoptosis. Where do you think the AST ALT level will be elevated? Necrosis or apoptosis? Only when there is a cell membrane damage, which means I have been having a discordance in medicine for many years. For many years, I know that virus causes apoptosis, and for many years, we also know that AST/ALT levels are elevated in hepatitis. I was not able to link it. Necrosis was discovered in around 2000s. It's very late. So whenever you find some discordance between what you read and what you see, I am missing on something. When necroptosis came, I know that yes, I do have apoptosis and also I have necroptosis in every viral infection. That's why hepatitis has elevated AST/ALT levels. As a discordance, I'm not finding something proper. Whatever you read should be proper. Whatever you read in textbook will be seen in patient. If it's not seen in patient, I'm missing out something. Go and research, go and learn more. You will find new things, right? That's what necroptosis is, fine? Great. So our next question. It's a very, very simple one. I want everyone here to answer. Yes, Guru. If you have any doubts, do comment. I'll answer your question. 30 seconds, I'll mute myself. Go ahead. Yes, Guru. Every hepatitis, be it viral induced or steatohepatitis or alcoholic hepatitis, there will be necroptosis. Okay, great. We have lots of answers coming inside. Great. Great. Fine. Again, let's go with a very, very basic understanding here. There are a few things which I want you to understand here and extrapolate. The answer is very simple. If you have not read this, you just saw immunohistochemical combination and went to the options, and without reading wrong answer, wrong match, you have to make sure in your exam you read the question correctly. Because a silly mistake, which I don't want any of you here to do it in the real exam, right? Desmin and carcinomas are not true. Where do you use Desmin? Desmin is a marker of carcinoma or a sarcoma? It's actually a sarcoma. To be specific, one type of sarcoma, which tumors will have Desmin positivity? One of the PYQs also had this. Which tumor will have Desmin positivity? Rhabdomyosarcoma, right? Desmin is actually positive for striated muscles. That's all. The striated muscle marker. The rhabdomyosarcomas are tumors from your striated muscle. It can be in the eye, it can be in the heart, it can be in any muscle, right? Any striated muscle, I'm going to have them, right? So since I specified striated muscle, can anyone tell me a marker for a smooth muscle? Smooth muscle tumors are leiomyomas, right? Fibroid. Marker for smooth muscle? Markers for smooth muscle. You know the answer. Okay, we'll derive to that. What are the proteins which comes to your mind when I tell about muscle? Perfect. Whatever Lakshmi said is the right answer, right? Actin is a protein in muscle. Yes. The proteins which comes to my mind in muscle is actin and myosin, right? I'll come to it more. I am trying to tell you a way to identify few things. Actin is definitely a protein in muscle, right? So leiomyoma, which is a smooth muscle tumor, will have actin. It will have smooth muscle actin. The smooth muscle actin will be present obviously in a smooth muscle tumor. That's what we abbreviate them as SMA. SMA stands for smooth muscle actin. That's all, right? Okay. The third option, leukocyte common antigen, which means a tumor coming from leukocyte. Can I say lymphoma is definitely a tumor from leukocyte? The LCA should be positive, right? LCA is leukocyte common antigen. It has to be positive in lymphoma for sure, right? Okay, so that statement is right. Vimentin is definitely a marker of sarcoma. Yes, CD45 is the other name for leukocyte common antigen, right? I'm just going to ask you one more question just to make sure your concepts are right. If I'm going to have a leukemia, will it be positive for leukocyte common antigen? Will a leukemia be positive for leukocyte common antigen? It's a very simple question. Though I don't use this for diagnosis, I'm just going to ask it. Will a leukemia be positive for leukocyte common antigen? It will be positive, right? It will definitely be positive. Though I don't use it for diagnosis, that's a different question. Every leukemic tumors, be it leukemia, lymphoma, they will be positive for leukocyte common antigen, fine? Then melanoma. Melanoma, S100 is a very, very specific marker. Instead of reading as melanoma and S100, I'll give you a different approach. What is the origin of melanoma? Or the origin of melanocyte? Are they epithelial tumors or the mesenchymal tumors? Where do they come from? Melanocytes come from origin, embryology. They come from neural crest, right? Perfect. In other words, any tumor which comes from neural crest are S100 positive, right? Guru, they are present in the basal layer of epidermis, but they are not originated from epidermis. They are originated from neural crest only, right? In other words, S100 is a marker of neural crest cells. That's all. Or a marker of neural crest derivatives. See, if I know this, I can extrapolate a few findings. One thing, your melanoma or melanocytes, they will be positive. So if it is a neural crest derivative, can I say even benign tumors of melanocytes will be positive for S100? Benign tumors of melanocytes also originate from the neural crest only, right? They also should be positive and will be positive, obviously, right? What are the benign tumors of melanocytes called as? Give me a name to that, which is nevus. It will be positive, right? Nevi or nevus will be positive for my melanocytes, right? Next, can I say, tell me which cell will myelinate peripheral nervous system? Which cell in my body will myelinate your peripheral nervous system? There's one cell in my body which can myelinate peripheral nervous system. Which cell is that? You know the answer. It's your perfect. It's your Schwann cells, right? So can I say schwannoma will be positive for your S100? They will be positive for an S100, right? They have to be positive for an S100, right? They will be positive for sure. It's not just schwannoma. Can you also say a nerve fiber, neurofibroma, will also be positive for S100? They will be. Schwannomas are positive for S100, and your neurofibromas are positive for S100. Okay, it's neural origin. That's all. The tumor which is positive for the neural crest derivatives. So anything which comes from neural crest derivatives are positive here. Paragangliomas, pheochromocytomas, some of the cells are positive. Neuroendocrine tumor, some of the cells are positive, right? So anything which has a neural crest derivative will be positive for the tumor, for tumor mark, right? So if you know the normal, Langerhans cell histiocyte also, because few of the macrophages have a neural crest derivative. That's also positive for S100, right? So my question is this. So if I know normal, I can easily know S100 and abnormality, fine. That's how you read all the immunohistochemistry, Mohit. So if you're still there, the way to understand and to remember IHC is knowing the normal. That's very difficult. It will take a time, but definitely we can easily understand IHCs, fine. Okay. Read the question carefully and comment on the answer. Let's discuss. I'll mute myself for a few seconds. Kwame, I'll take your query. See, blastemal tumors like neuroblastoma, it's like a neurological derivative, right? They will be positive for a marker, which is, it's a very immature tumor. So I know it's neural origin. So they are positive for primarily for marker like synaptophysin and chromogranin, right? So they are neurological origin. Yes, the mature component, when the same blastemal component matures to become your Schwannian component, because neuroblastoma also can have Schwannian differentiation. Once it differentiates, yes, they can be ascended positive, right? Okay, we'll come back to this question. Diagnosis: chronic alcohol abuse, gallstones brought to the emergency room, and there is an elevation of amylase and lipase. I'm sure everyone will know the answer here. It's a classical case of an acute pancreatitis, right? It's a very, very classical case of an acute pancreatitis, right? Here, acute pancreatitis, my only question, the answer is very simple here. It's neither of these. Answer is option A. That's not a difficult thing at all. All of you wrote option A, right? Now tell me, acute pancreatitis will have what type of necrosis in microscopy? That's my question. I'll give you options: coagulative, liquefactive, caseous, fat, fibrinoid. Those are the only types of necrosis anyway. What type of necrosis will be seen in case of an acute pancreatitis? You should know the answer. You guys know the answer. A very simple question. Okay, we've got a competition between fat and liquefactive. Coagulative has joined the competition. Great. Fine. Now let's see. The confusion comes because the base is again a problem for me. If I know the basics, definitely I'll have no problem at all. When you tell coagulative necrosis, what is the common etiology which comes to your mind? What's a common etiology comes to your mind when you think of an coagulative necrosis, or common example? I'll come to it more. Common example when you think of coagulative necrosis, it's undoubtedly ischemia, right? Infarct or ischemia of a solid organ, it results in coagulative necrosis. Perfect, right? Perfect. So in pancreatitis, is there any ischemia? Is ischemia the reason for pancreatitis? No, ischemia is never the reason for pancreatitis, right? So ischemia induced necrosis will not be seen in a pancreatitis, right? So that's not going to be there at all here. So coagulative necrosis is out of question, right? So I'm trying to rule out one by one. That's all. Fine. Okay. Now someone commented brain, right? All solid organ has coagulative necrosis except brain. What type of necrosis happens in brain? What type of necrosis happens in brain? I'm sure you know the answer, right? It's a very standard statement which everyone knows, and which everyone knows that it's liquefactor necrosis, right? You must have read this from your second year of MBBS. They'll say that every solid organ, in fact, is going to be coagulative necrosis except brain, which is liquefactor. You must have asked then and there to your teacher why brain alone has liquefactor necrosis. Because the question why is what is going to give me many answers. We'll see why, right? So brain, have you touched brain in your autopsy, in your anatomy dissection? Brain is hard or soft? Just tell me that answer. We can easily explain why brain has liquefactor necrosis. Brain is extremely soft, right? It's extremely soft to touch. There's one more part of the body which is extremely soft. Touch your tummy. If you're not a bodybuilder, everyone's tummy has an amazing amount of fat, right? It's extremely soft. So fat is very soft. So brain is fully made of fat. So when we read necrosis, in coagulative necrosis, the most common mechanism of destruction of coagulative necrosis, protein degradation. So if I destroy protein, can I destroy brain, which is rich in fat? Is that possible or not? It's again a very simple question, right? So in coagulative necrosis, I'm going to have protein destruction. If the same mechanism happens in a brain, in fact, can I destroy brain? I cannot. The only way to destroy brain is I need lipase, right? I need lipase, right? So what happens is brain is unique from other organ because extremely fat rich. So only when I have lipase, only lipase activation can destroy brain. Okay. So now the mechanism of liquefactor necrosis is not protein degradation. The mechanism of liquefactor necrosis, enzyme activation. Now tell me, what is the mechanism in acute pancreatitis? Mechanism in acute pancreatitis, is it protein degradation or enzyme activation? This enzyme activation, right? It is obviously enzyme activation. The trypsin, chymotrypsin, enzyme activation. So in pancreatitis, what type of necrosis will I see? I will see liquefactor necrosis, or I'm going to see your coagulative necrosis. You obviously are going to see liquefactor necrosis. You will see liquefactor necrosis in case of an acute pancreatitis. Some of you answered your pyrenoid, right? Sorry, fat necrosis. I'll come to that. The reason why I'm getting confused with fat and liquefactor is we always remember a case history saying that in case of an acute pancreatitis, there will be fat necrosis, but not in pancreas, in the peripancreatic fat and in omentum. Like Mohit said, the chalky white deposit, the saponification and calcification, all of them happens in omentum, not in pancreas, right? So if you have any question on pancreatitis, be very careful. If it's in the substance of pancreas, it's going to have liquefactor necrosis only because enzyme activation. If it's in the peripancreatic fat, or if it's in omentum, it's going to cause fat necrosis. Okay, as a two different thing. So you do remember them. See what has been asked. Yeah, qualificative necrosis, the other name for liquefactor necrosis, is an older term, so we will use term liquefactor necrosis itself, right? So based on this, you should know the answer. Okay, again a very simple question. Look at the question, look at the image also, correlate, and then let's come to a conclusion, right? I'll mute myself for the next 30 seconds. Okay, again, we've got a good amount of response for option A. Let's look at it. Let's look at it whether it's right or not, right? A 42-year-old female presents to the physician with weight gain of 10 kg over the past 6 months. Okay. Responsible for the disease responsible, the image is shown in the microscopy, fine. Great. So here, it's hypothyroidism or hyperthyroidism? That's the first question which I'm going to ask you. Hypothyroid or hypothyroid? Hyperthyroid. It is definitely hypothyroidism, right? So weight gain is a classical feature of hypothyroidism. Perfect. So in hypothyroidism, I can have two organs involvement. I can divide them into a primary hypothyroidism and a secondary hypothyroidism. Can I say when my pituitary is destroyed, so when there is no TSH, can that also result in hypothyroid state? Like some of you said that T3, T4 will be reduced. Can that also cause hypothyroid state? It can, right? It can definitely cause it. So these two are unimportant for me, right? They're not possible for me. ACTH is not directly related at all, right? Secondary hypothyroidism definitely possible. I have to know whether the reason for this hypothyroidism is primary or secondary, right? That's all. So I have an image for that. If you look at the image, there's actually the image of a thyroid. The thyroid exercise specimen, you can look at this guy. That's your colloid. You can see the pink color colloid. In the colloid or in the thyroid image, I'm seeing this classical finding. So if you see this structure, what I've marked now in a lymph node, what will you call them? I'm going to see the same structure in a lymph node biopsy. What will you call them? Can I call them lymphoid follicle? Does it look like a lymphoid follicle? They do look like lymphoid follicle, right? The lymphoid follicle, in case of a thyroid, in the thyroid biopsy, what is your most probable diagnosis? The most probable diagnosis is your Hashimoto's thyroiditis. Now so the image is very important for me to know whether it's in primary hypothyroid or a secondary hypothyroid. Hashimoto is undoubtedly in primary hypothyroidism. So in case of a primary hypothyroidism, what will happen to TSH? It has to be, and it will be elevated, right? So increased TSH is the answer. It's a very simple answer which you guys told. But you have a similar question. Look for what organ is being shown. I can show you an image of pituitary adenoma. Then it's going to be decreased TSH, right? So it can be anything which can cause hypothyroidism. So you have to rule out whether it's primary or secondary. That will easily help me, right? TPO antibodies, right? Since Ali has given us an input, I want to take a detour from that and just we'll go back and I'll come so on again, right? Let's take Hashimoto's thyroiditis here. So Hashimoto's an autoimmune disorder, right? Most of you guys know that Hashimoto's an autoimmune disorder, right? How do you think destruction starts? The TPO antibodies is the effect of the destruction or it's the cause of the destruction? I just want this answer because based on that, my hypersensitivity will change. The anti-TPO antibodies, which you must have read in Hashimoto's, is the effect of destruction or it's the cause of destruction? You guys know about anti-TPO antibodies for sure. I know that. It's an effect of the destruction, right? It's an effect of the destruction. It's not the cause of destruction, right? So what happens in Hashimoto is, in Hashimoto, it's primary T cell mediated destruction. It's not a problem of the B lymphocytes. It's T cell mediated, right? So what happens? It's primarily CD4 and CD8 mediated destruction. This T cells destroy thyroid follicles. When they destroy thyroid follicles, as an effect of this destruction, my body is going to develop anti-TPO antibodies. This also will cause little bit damage to the existing thyroid, but it's effect of the destruction. Why I want you to know this is, now if I have a question saying that, a random cooked up question, right? What type of hypersensitivity is there in Hashimoto's thyroiditis? Type 4 or type 2? What do you think? What type of hypersensitivity will be Hashimoto's? Type 4 or type 2? It has to be type 4. It is cell mediated. Yes, both will be a better option if both are available for sure. But the initial person who's going to cause is cell mediated, right? It's a cell mediated hypersensitivity. It's a cell mediated problem. It's type 4. Type 2 is not the primary mechanism of death. This I want you to know because there are lots of diseases which happens like this. Pernicious anemia. What antibody comes to your mind first? I'm saying pernicious anemia. What do you think which comes to your mind first? Antibodies to parietal cell or intrinsic factor, right? That also is an effect, not the cause. There also causes T cells. T cell mediated destruction of my parietal cell, which will result in the antibody production. That also is type 4, not type 2. When I take type 1 diabetes mellitus, have you read about something called as an anti-GAD antibodies in diabetes mellitus type 1? You must have read about this, right? Because these are used for diagnosis. That's the reason it keeps on coming in my mind, fine? I'll tell it, Guru, just give me a second. Right? So in type 1 also, type 1 diabetes mellitus also, anti-GAD is an effect. The primary destruction is based on T cell. Type 1 diabetes mellitus also is type 4 hypersensitivity, not type 2 hypersensitivity. It's always type 4. The T cell causes destruction, and then I'm going to have an effect of antibodies thyroid peroxidase, right? Your question is very good, right? Why does thyroid peroxidase antibody is produced when a follicle is destroyed, right? That's a very simple and a very, very good question. So let's say that I'm having a T cell destroying a thyroid follicle. Okay. So let's assume that my pencil here is a thyroid follicle, right? So can I say my immune system will know that this is self-antigen? Will my immune system know that this is self-antigen? If this is thyroid follicle, can my immune system know that it's self or not? They'll know, right? Because they've been taught in the thymus, this is self, this is not self. So my T cells come and destroy it. I'm going to break this. If I break this pencil, I'll have different fragments. Can my immune system identify the fragments as a self-antigen? Possible or not possible? Not possible, right? So whenever it's a T cell mediated destruction to a follicle, what happens is it will create new antigens. It will create new antigens. When a new antigen happen, this new antigen will be considered foreign. So in thyroid, in your Hashimoto's, the new antigen is TP2. So I'm having antibody against that. That's why I'm having autoantibody response, right? You must have post-COVID, there are lots and lots of autoimmune conditions, right? The reason is same. Because here also the virus does the same thing. The virus triggered lymphocytes. Lymphocytes destroyed lots of protein in my body. They created lots and lots of new antigens, and my body thought them as new and destroyed everything. Right? That's why autoimmune reactions are very, very common after COVID. You're battling still with autoimmune reactions, right? From head to foot, you can have autoimmune reactions due to COVID. Not just COVID, any viral infection for that matter, right? Great. Okay, this was a question. We took a detour. Let's go to the next. Read the question carefully, look at the images, and then comment on the answer. I'll mute myself for 30 seconds as usual. Okay, Satvik is going to see others. It's a very simple question. Only problem might be if you overthink, you might go to the wrong answer. Just look at the image, read the question again, you know the answer easily. And most of you are going to see amazing, right? I'll tell you the easiest way to identify this question. Though this is an PYQ, the images are not good at all. It's a very, very crappy image, right? I'll look at the question. Whenever you have an image-based question in your real exam, don't look at the image first. Image is secondary for me. Except if it's a spotter, yes, image is important. 45-year-old person. What do you think is the age group of dysplastic kidney or multicystic dysplasia? Age group. What do you think is the age group of multicystic renal dysplasia? It's seen in children, right? In neonates, it's less than one. Non-functional kidney in a child, I think of multicystic renal dysplasia, right? It's seen in children. It's not a problem seen in 45-year-old age group. So definitely I can rule that out. Right? Next, ADPKD. Can I say ADPKD can be seen in adults? Definitely possible. I can definitely see ADPKD in adults. How do you think ADPKD will present? As recurrent abdomen pain and fever or as renal failure? How do you think ADPKD will present? Abdomen mass and renal failure or abdomen pain and fever? It's in general renal failure and abdomen mass, right? It will not present as renal pain, abdomen pain or fever, right? So my presentation is not of an ADPKD. They don't present as fever, they don't present as pain, and they don't die after 10 days. They present as an abdomen mass. It's not a fatal disease, right? Next, last option. Renal cell carcinoma. Age group when it fits. 45 years, yes, year old I can have renal cell carcinoma. And how do you think the patient will present? Will they present with hematuria, abdomen mass, or fever and death in 10 days? They'll present with hematuria. So I can rule this out. I can rule this out. I can rule this out. Even if you don't pick up the answer, like what Ayush said, thyroidization of tubules, even if you don't pick them up, I can easily tell what's the answer. It's hydronephrosis with chronic pyelonephritis. Actually, these are dilated pelvic alley system because of the hydronephrosis. And thyroidization of tubules is a classical finding seen in chronic pyelonephritis. We'll just look at why thyroidization. See, always why gives us lots and lots of inputs. I'm sure all of you guys know about thyroidization, right? So if you have a patient with an chronic pyelonephritis, can I say pyelonephritis is damage to the interstitium of the kidney or renal parenchyma, right? In a patient with a chronic pyelonephritis, will the tubules be affected? Yes or no? There'll be chronic damage to the tubules, right? So definitely in chronic pyelonephritis, in case of chronic pyelonephritis, I'm going to have damage to the tubules. It will happen. So when you have damage to the tubules, what is the function of a normal proximal convoluted tubule? It's a very simple question. What do you think is the function of normal proximal convoluted tubule? It is reabsorption, right? It's simple reabsorption. So in these patients, the absorption will fail. If the absorption fails, the reabsorption fails, the patient will not be able to reabsorb sodium or your glucose or water, nothing. They will not be able to even absorb protein. I don't mind about water or glucose or sodium because I can't see them. But at the same time, when there is a damaged tubule, there will be a reduced protein reabsorption. So when a reduced protein reabsorption happens, will the patient have proteinuria? My reabsorption fails. So will the patient excrete lots and lots of protein? Is that a possibility? There's definitely a possibility, right? That will be there. At the same time, I will have the tubules, which are normally like this with my beautiful epithelium cell. That will become like this. It will be destroyed. At the same time, it will be filled with protein because protein in microscopy is pink in color, right? So this protein, which is not being absorbed, is seen fill the tubules. So which looks like a thyroid or which looks like a colloid. Colloid looks like that. So I call them thyroidization of tubules. Right? The thyroidization of tubules is nothing but finding seen in any chronic tubular damage. It need not be chronic pyelonephritis. Any chronic tubular damage, I'm going to have the same finding. That's all. So just I'm going to ask you one question. Will multiple myeloma have more and more and more protein secretion, and will multiple myeloma destroy tubules? Can multiple myeloma destroy tubules? They can destroy tubules for sure, right? So in multiple myeloma, there's an oversecretion of the light chain, and that will destroy tubules as well. So in multiple myeloma, I don't call it thyroidization. I call them myeloma cast nephropathy. So it's same thing. It's the same pink color in microscopy for me. I call them myeloma cast. The treatment is different. The diagnosis is different. Fine. So this finding, like some of you guys said, there's a classical thyroidization. These are renal tubules, which looks like that. See, Guru, it's not based like whole or partly. It's based on the severity and the accumulation. That's all. Even if you look at this, let me zoom this. So it's getting blurred, but still, can you say that I do have normal tubules here? Some of them with no protein deposition at all, will still an intact lumen. Yes. So I do have both normal and abnormal. I cannot say that it should be full or it should be partly. Some of them it's completely destroyed. It's not reabsorbing at all. It'll look full. In some of them where the still reabsorption remains even a little bit, it will be partly filled. That's it. Fine. Okay. Okay. Let's go to one more question. Comment on this and let's see. Okay, okay, okay. Great. Let's see if it's right. Most of you got on the D. 4, D, D, D. Great. It's a finding seen in autopsy, so I don't have any clinical feature at all. I don't know what's the cause of death, and this is not related to the cause of death also. It's not aneurysm because what I'm seeing is not blood vessel. It's not Zenker's diverticulum. It's definitely not your Zenker's diverticulum happens in the pharyngeal region, right? It's not pharynx for sure, right? There are two options: colonic diverticulum, Meckel's diverticulum. How did you guys say it's Meckel's diverticulum, and why it is not colonic diverticulum? Right answer is one thing for sure, but I need to know why it is not colonic diverticulum. That's what makes us learn more, right? The option D is right. I am not denying the fact it is Meckel's diverticulum, but why not colonic diverticulum? Quite a few of you have answered Meckel's diverticulum. Okay, Barry, I'll take your question. True diverticulum. What does a true diverticulum mean? Can anyone help? When will you call something as true diverticulum? I'll come to that issue as well. When will you call something as true diverticulum? Coffee bean. I'll come to that as well. All layers. Perfect, right? That's all, right? So in a gross image, can you say all layers are involved or not involved? It's a gross image, right? It's an autopsy image. Can you say that in this image, all three layers are involved? That's very difficult, isn't it? That's very, very difficult to do that, right? Ayushi, I'm coming back to your question. Incidental finding, colonic diverticular can also be incidental. Unless and until it causes diverticulitis, colonic diverticular will not come into the picture at all, right? It will be incidental only. Now tell me, why did you guys answer Meckles? Because it was Meckles and it was attracting you more? If that's a reason, you might fall in trap for the examiner if I have an exotic diagnosis there. That's why if it's the exoticness of Meckles attracted you and colonic diverticular didn't attract you, that is a wrong thing. A simple question. The image given here is small intestine or colon. The answer always comes from basic questions. That's all. Colon or small intestine? That's a small intestine, right? It's not a colon. Colon will have your tinea coli. I don't have that. It's not colon. Colon will have the hostrations. I don't have the hostrations. It's a small intestine. Now, obviously, it cannot be a colonic diverticular. That's all. Colonic diverticular will happen in the colon. Will have these perfect hostrations. Will have the tinea coli and have everything else, right? So it's a small intestine. A small intestine, the only diverticular seen in small intestine of the options is Meckel's diverticulum. That's the answer, right? You're right. Answer is Meckel's. I'm not denying the fact, but you have to know why Meckel's also, because that's very important for me so that I don't make mistakes henceforth, right? Okay, fine. I think I'll end the discussion today here. Maybe around maybe in the morning tomorrow or sometime tomorrow, we'll have one more quick discussion about a few more questions. If you guys have any doubt, do let me know. If not, we'll call it a day. Any doubts? No doubts? Okay, great. If there are no doubts, we'll call it a day. See you soon. Till then, bye bye. Thank you for your time. Guru, it has no relation to the cause of death, right? The question clearly says that it's an incidental finding. There's no relation to the cause of death. So it's an autopsy finding. That's all. It's nothing related to the death of the person. It's just an autopsy finding. That's it. Fine. Michael doesn't cause death. Okay. Thank you for your time, guys. Thank you. Bye bye.